Thank you, Dennis. Sorry I'm coming to you guys live from this amazing lobe auditorium bacteria because I was just doing a revision one of these cases. So, bringing real life expertise straight to the webinar. So outline, we'll do anatomy, how these injuries happen, first time dislocator management, some non-op treatment, some surgery, and then specific controversies. Now, the problem with all of these controversy talks is always you're probably going to leave with a lot more questions than answers. Ariana did an incredible job giving you an algorithm. I am not going to do that because I'm just not as good as her. Also, because there's not as good information here, and a lot of it is experience, super patient specific. So it gets really hard and nuanced to give more algorithmic versus more generalizations, which I think will be helpful on how you can approach things. So, talking about anatomy, this is one of my favorite pictures in the world. So, there's a lot of things that keep the shoulder stabilized. So, starting with bony constraints. So, the shoulder is by far the most mobile joint in the body. That's great. That lets us go like this. Raise your hand to ask questions of people like me, very knowledgeable. However, the problem with that mobility is that comes at the sacrifice of constraint. So even though we call the shoulder a ball and cup, it's a little different than the hip. The hip is a true ball and cup with a concavity that where you get bony restraint. The shoulder, conversely, is really just almost like a dish rather than a cup. So the bone provides only 20 to 30% of that restraint. Then, as you can see in the picture here, you have a labrum. That labrum increases the depth of that concavity by as much as 50%. I don't know why I'm using my mouse because you guys obviously can't see that, but you'll have to take my word for it. Then there's the joint capsule, which is attached to that labrum. And then there's the glenohumeral ligaments, which you can see in the center there. For our purposes, by far the most important is that anterior inferior glenohumeral ligament. That's the one you see at the bottom. That's what helps us in that flexion or abduction external rotation position from the humeral head coming out. So in that 90-degree position. Now that those were passive. Passive restraints mean they're always working. They don't need muscles to fire. Think of them the way like bones or ligaments. They're always taut. Then you have your dynamic. So that's going to be a repeat because it didn't tap you over. But what you can see on the right is you can see our rotator cuff muscles. So our rotator cuff is the primary dynamic restraint. There's those four muscles, the supraspinatus, infraspinatus, teres minor in the back, and then a subscapularis in the front. What those do is those provide what's called a concavity compression. So beyond helping us lift our arm, when those rotator cuff muscles or and tendons are firing, they help keep that humeral head pushed against that glenoid dish. What that does is that helps make up for the fact that even though that's a shallow bony concavity, this pushes it against it to give us that extra restraint, allowing us to rotate. That's why if you have a massive rotator cuff tear, you try to rotate, you don't have that concavity compression. Nothing's holding that bone against the humerus against the glenoid, and then the ball starts moving in ways preventing your shoulder from working. So now that we understand a little bit about what's supposed to work, let's talk about when things don't. So, in terms of injury mechanism, the worst or most at risk position is what's called when your arm is abducted, externally rotated. This is the worst thing you could have it. Then, if think about a football tackle, so someone's like this, someone pushes posteriorly on the humeral head or on the humeral shaft, that's going to bring that humerus forward, as you can see in the picture on your right. When that ball moves anteriorly, it's going to do several things if it's going to dislocate. One is it's going to tear that labrum in the front. Two, the back of the humerus, as you can see here, is going to hinge on the front of that glenoid. Two things are going to happen during that. One, as you see in that picture, a little divot in the humeral head is going to form. That's going to increase your risk of dislocating in the future. That's called a Hill-Sachs lesion. And then two, some of that bone of the glenoid is going to be lost because the humeral head is in strong force hitting against it. So now you have a torn labrum, torn capsule and ligaments, loss of anterior bone of the glenoid, and then a little bit of loss of bone on the humeral head. So, 3 to 4, depending upon the extent of the injury. So a lot of things go wrong, which makes us have to keep people out for a little while. So this is how that happens um, in sports. In terms of what we do for it. So for a lot of us, if you're a sideline doc, like a lot of us have experience with, if possible, you're going to try to reduce this dislocation on the field. First rule of orthopedics, whenever you can, reducing a joint is going to usually make everything else better. So if they're, have a problem with their neurovascular status, the first thing you want to worry about is getting everything back where it's supposed to be so nothing's pushing on something that shouldn't. If you're on, like I said, if you're in a sideline field, trying a reduction before an X-ray is reasonable. If you're more in a medical center, then it's much more reasonable to get the X-ray first, understand the type of dislocation, where it is, and then do the reduction in a controlled manner. In terms of immediate follow-up, which is probably going to be the most relevant for us. So for a shouldered instability, you do want to immobilize them, but not for an extended period of time. Some patients want to stay in that sling and live there because they just had a very traumatic event. Ariana or Dr. Lott was just talking about the psychological readiness, which is going to be relevant for us too here. This is a real traumatic event. They were doing something they've done their whole lives. They playing football, going for a catch, something they might have been doing, 15 years, and for the first time they had this what seems like a catastrophic injury to them. So there's a huge psychological component to it. They're going to want to live there, but we need to get them moving. That's part of our job. So yes, we do want them in a sling for about a week. However, after that week is over, we really want to get them moving with first physical therapy and then a structured rehabilitation program. We do want them to see in some sort of provider for follow up for physical therapy and an advanced imaging follow. This is one of our controversies that we'll talk about. One thing that I would really want to encourage everyone not to miss, because we see this all the time, is one, neurovascular injury. So when I was just starting out practice, not that I'm so far in, but I wasn't expecting to see so many nerve problems after dislocations. Now I thought, you read about that, you see that question in a textbook or on a test, but then you see so many dislocations without nerve problems. I just thought it was something that could happen, but the incidence was fairly low. But I've actually seen some pretty catastrophic nerve injuries so far where people have severe brachial plexus palsies where they can't even lift their wrist, complete wrist drop after what seems like a simple dislocation. So, if you see them in the office, they're in the sling, they're saying, yeah, their pain's well controlled. If you don't do that neurovascular exam, ask them to move all their fingers, move their wrist, you could easily miss that. And then you have them to go start PT and they follow up 2 weeks later and say, yeah, my shoulder's moving, doc, but I still can't move my wrist. And then you've just lost time to help move that injury in the right direction. So that's something to consider. And then this one's a little outside of the realm here, but it's just so important. We're talking about athletes, we're talking about younger patients. This has that cascade I talked about where the primary lesion is going to be that Bankart or anterior labral tear. Older patients, think over 40, if they have a dislocation, probably after a fall, you have to be worried about the rotator cuff. I have seen many, many patients in my office come after dislocations where it have been ignored. It's been 3, 4 months where they can't lift their arm anymore. And they're like, yeah, someone just kept telling me to do PT. I've been doing PT, hasn't been working. What's going on is they have a massive rotator cuff tear and no one got an MRI. So for a younger patient that you're just trying to in season get back to play, I think the decision to get an MRI after a shoulder dislocation is very controversial, and there's points on both sides. For an older patient that had a dislocation, I would encourage every provider and everyone thinking about practicing medicine to get that MRI after a first time, because that could be the difference between an easy arthroscopic surgery and a reverse total shoulder replacement in a relatively young person. So let's get to our first controversy. So in season return to play after a first time shoulder dislocation. So there's a few things to consider. The pros, well, early return is possible. So if you're like in week 2 of a football season and they want to, they're a senior go before last year before college, they want to play, you can do that. You can probably do that in after 2 to 3 weeks, which we'll talk about. The risk of that is there's a really high risk of recurrence. So this is one where you really have to take the patient, talk to them, risk benefits, share decision making. In terms of what that recurrence risk is, well, it's probably most of the people we're talking about today. So it's worst in patients who are less than 25, and it's worst in contact athletes. In terms of what we can do here, there's a one of the Sully braces. What this theoretically does is it keeps the shoulder in out of that position of risk, so it keeps it away from that flexion abduction position. I'll be honest with you, there's very limited evidence for that. It gives, in terms of psychological readiness, it gives people a supportive feeling. It does theoretically make sense from like a face validity standpoint, where if your shoulder can't go here, why would it not? How could it dislocate? but in reality, study after study has been at best mixed. So yes, I would put a football lineman or something in this to prevent a dislocation. I would tell them I'm not sure if it's going to work, but they're going to feel better in it. And so in terms of return to play, what to think about, um, there's so operative versus non-operative. So in that, this is the second side of that coin. So for in season, we're generally going to try to treat non-operatively, get them back, but there is growing evidence that treating the first time shoulder dislocation operatively has value. So in terms of non-op pros, well, you avoid surgery. You get there's risk with any surgery, even for me, and no matter how good I am. The faster return and the con higher risk of recurrence if you treat non-op. Surgery wise, pros, well, there is a lower risk of recurrence. You're probably preserving their joint because every time your shoulder dislocates, you're damaging your cartilage. So that's putting you at risk for long term arthritis. And studies actually show higher ultimate patient satisfaction when they're treated. Cons, there's all the risk of surgery and particularly missing the rest of the season. Currently, trend wise, we've been trending more and more towards surgery. Is that driven just by me trying to make as much money as humanly possible? Maybe. But it does seem like the literature is supporting more and more stabilizing it. This is beyond this talk, but the surgery is easier after a first time shoulder dislocation than after a 10th time shoulder dislocation. So that's just something to think about. In terms of what your surgical options are, and this is super outside the realm of this, but just to give people an idea, there's a soft tissue surgery, which is repairing a labrum, which you can see on the top right over here. This tissue is lifted off the glenoid bone. You can do something called a remplissage, where you fill some of that bone in the back, and then that helps decrease your recurrence rate. In terms of criteria to return, there's pain-free range of motion, strength drills, which we'll talk about, and then timing. Traditionally, it's been 4 to 6 months. A more accelerated push, which is 3 to 4. Now, the real evidence gap is there's a limited high-level data, so it's about functional testing, which Dr. Lott started talking about for our ACL, which we'll talk about here too. So this brings us to our next controversy. So, what a remplissage is, this harkens back to what we started for in the beginning when there's a big defect in the back of that humeral head that can increase your risk of dislocation. So what you can do is you can fill that defect, as you can see in that bottom right picture, with the capsule and the infraspinatus tendon into the back of the bone. That's great. That limits your recurrence. But for our overhead throwers, that might decrease their velocity. That might limit just a hair, a couple degrees of external rotation. For you, me, a football player, probably doesn't matter if you lose between 3 and 10 degrees of external rotation, which is what studies show. But if you're a pitcher, if you're a shortstop, if you're an outfielder, that could be the difference between a scholarship and giving up baseball. So in remplissage and overhead athletes is still a bit under investigation. We have very limited to no high level data, but this is something that we try to avoid if we can. Other surgery procedures. So then there's some, if you're before we talked about just fixing some of the soft tissue, here we're fixing the bone. So if the bone, you can either do something called the Latarjet, which is a bony procedure, or distal tibial allograft, which is from a cadaver. W- Picking between those two doesn't super matter. What you're doing is for these patients typically who have significant bone loss. So you're talking about 10, 20 dislocations, a little bit longer to return, 5 to 6 months. Overhead athletes even more because we have to be careful about the forces they're putting on. But what we really care about is our next controversy. So it's the role of imaging. So here in the top two pictures, you can see that extra bone that's been placed on the front of the shoulder. There it's held with a fixation device, two buttons. And in the beginning, that's 2 weeks post-op. So you can see there's a cleft between the native glenoid and where that bone is. Then if you look 6 months post-op, so they got a repeat CT, you can see that cleft is gone. So that is what's called an incorporated graft. So now that is healed. The question is, so that's great. That makes you feel better. That makes the athlete feel better. It makes them feel a little more confident that they can go back to whatever sport they're playing. But the question is, does everyone need that? Do you need that confidence to show a healed graft? Can you just go based on timing? The question is, what is the value? So if it's healed, are you automatically going to let them go? If it's not healed, but it seems like there's a fibrous union, are you automatically going to hold them out? how are we incorporating that? That's something I think most of us don't know, so that's just something we have to think about. The big question, I think, for all of these things is exactly what Dr. Lott was getting at with ACLs, which is time versus function. So after any shoulder, time helps get for healing after surgery anyway. So it's easy, it's standardized. You can say, 4 to 6 months for soft tissue, 5 to 6 months for a bony procedure. That's easy for you to follow. That's easy for the athlete to get that criteria in their head. Okay, I'm going to go, have surgery tomorrow. About 6 months from now, I'm going to be able to start getting back in the game. That's helpful. However, the problem with that is incredibly obviously not individualized. Every patient is different. Their sports are different. Their demands are different. Their psychological readiness is different. So, given some sort of just standardized time is going to be really limiting to getting the most for our patients. So then you could do the opposite, or at least the flip side of that coin, which is functional. So functional would be based on a series of criteria. It's going to be the same criteria that we would just use to get to return after non-operative management. So that criteria would be full painless range of motion, full strength, able to start returning to sports specific activities. So if you're a wide receiver, think being able to safely, comfortably reach out to grab a pass, then moving on to non contact playing, then contact playing, and then eventually full go for games. That's going to be the same rough functional algorithm, whether you're just dislocated for the first time and you've been out for a week, or if you're coming back from surgery. It's always the same thing: range of motion first, then strength, sports specific drills, non contact, contact practice, game. About 6 steps. Um, that is one of the things we don't have an answer to. Much like Dr. Lott, I do both. I do have a time component, and then I use that functional readiness or those criteria to make sure they're getting along on that time frame. So if they can't do those things, even if they've had their 6 months, I won't let them back. The problem is really the converse. So what do you do when someone at 4 months can theoretically reach their all of those functional criteria, but you're just not sure about the healing because it's a little early based on the current evidence that we have? What do you do about that? Me, I'm relatively early in my career. I still keep it pretty conservative, and for most things, I keep them out for probably about 5 to 6 months or at the earliest. Maybe some more established gray-haired surgeons might be a little more aggressive, let someone get back earlier. It would depend a little for me on the circumstance. So if you're just a high school kid who got hurt and you're trying to get back for your senior season, but I played football in high school, I can promise you whether or not I got back a week earlier is not making a difference for me, my team, or my future. Like if I had that orthopedic surgery, I would, my surgeon would have kept me out. I would keep that version of myself out. However, if it's the opposite, if it's a college kid trying to get a scholarship, a few weeks here or there might make a difference. That extra month might be the difference between being seen by that scout or not. There, you again have to use that multidisciplinary or patient centered approach. Talk to them about the risk and benefits, and really, put it in their hands to a degree while giving them the education to make an informed decision. The next controversy, let's say they meet that functional readiness and the time readiness is psych. So, like we alluded to in the beginning, having this sort of dislocation event can be incredibly traumatic. Like I said, you do something you've done your whole life every single day, and then one day the worst thing in your world happens, and your shoulder pops out. You have to be rushed to the emergency room. You get anesthesia. You get put in place. You're put in a sling. That's terrifying. So coming back from that can be really hard. The last time you did this happened, and now you're trying to play basketball again for the first time in 6 months. So assessing someone's mental readiness is very difficult. There are some validated tools. There's something called a shoulder instability assessment tool or return to sport index. This is, I would say, getting increased use. I don't know that it's fully ready for prime time yet in terms of being the end all be all of letting someone return, but it's at least something to hang our hat on to let the patient know we're thinking about it. They should think about it. And then it is something that I talk about to them as they are getting ready back to sport. Some are chomping at the bit and can't wait, but I've been surprised by people who I would have thought would have been, counting down the days to play. And then they're the ones really pushing the brakes. So it's really hard to know what your patient is going to feel, and I think you just have to approach that with open mind and compassion and understand where they could be coming from. So in terms of future directions, I think coming up with more objective physical tests. One thing that Dr. Lott had at her disposal for her ACL patients, which was great, was that the single leg hop test, the quadriceps strength test, or side to side difference. Those are at least, while not perfect, like she said, at least there's something. There's something that you can hang your hat on, some sort of objective criteria to give a patient to say, all right, I need you to be at least this for me to feel comfortable. For the shoulder, we don't really have that. You can do like side to side, cuff strength, but that's always going to be pretty similar pretty quickly. Really, it's more the shoulders, scapular stabilizers, which is really going to probably be that determining factor. But we don't have amazing assessments for that. So coming up with something that might be some sort of objective metric would be really helpful. Then two, the psych readiness, like I was speaking about before, we have a start with that test, but that'll be need to be validated further and probably made a little bit more robust. And then from a technical standpoint, I just think this is awesome and I'm badass for doing it. So here's a picture of what's called an arthroscopic DTA. So we talked about two types of surgeries in general. One is a purely arthroscopic surgery that fixes the labrum. One was an open surgery that puts more bone in the shoulder. This is the marriage of the two, where arthroscopically you put more bone in the shoulder. Technically, it's challenging, but I've now done quite a number of them, and I've been really, really happy. I think my guess is this will be the future of all shoulder instability surgery, but it's just hard. So we all have to, as a community, learn how to do it. So in summary, return to play after instability. It's controversial. There's both time and functional components. This really, really requires individualized treatment. Probably, I think, potentially more than my ACL patients, because sport type is so different in terms of an overhead thrower versus a contact athlete versus, a tennis player is going to be very different. Timing's different, goals are different. You really have to get into the nitty gritty with them, and it's a lot more nuanced than just 6 months you're good to go. Remember psych readiness. This is really traumatic for them. It's going to take a lot for them to get back to playing both functionally and mentally. And then shared decision making. I know that, it seems like a cop out when people say that in talks, like you got to talk with your patient, but especially given our lack of clarity on a lot of these things, it's there's no right answer to most of these decisions, and it's going to be up to ultimately the patient. It's our job just to give them those risks and benefits. And, like I said, it's not an excuse. You're not just not helping them. You're not telling them, you're not just being patriarchal. You're letting them make the best decision for them, and they're probably going to know that best. Thanks.